Welcome to eCrit Podcast. This is our episode number 119, and today I'm joined by my co-host, Dr. Josh Chacko from India. Welcome, Dr. Chacko.
Hi, Swapnil. Good evening. How are things up there in Sydney?
Things are pretty stable. Summer is starting. ICU, as usual, getting busy. Nothing too bad, I must say. How's things there?
Life goes on as usual. We are also not particularly busy at this point of time. Things have been fairly quiet in the last few days.
That's good. As a healthcare, we needed some breather for a lot of the staff. I think this is probably the time for really refreshing and recharging the batteries. I think it's good that people are getting a little bit quieter time in most of the ICUs now. So today we are going to do a journal club, and this is a quite unusual trial which was recently published in New England Journal of Medicine. And the trial is called as ECLS Shock Trial, which stands for Extra-corporeal Life Support in Infarct-Related Cardiogenic Shock. Now, as we all know, cardiogenic shock is common and develops after MI in roughly around 10% of the hospitalized patients, and it's a leading cause of death among the patient who develop MI. Now, often this patient population will be admitted to intensive care unit for further management of cardiogenic shock, and that's why it's kind of relevant to us in intensive care. And the results of this trial are good to discuss and kind of think about what this trial helps us to understand. The treatment for myocardial infarction is pretty standard now, where patients do get immediate revascularization using the primary PCI. And often the practice, if the patient is in cardiogenic shock post-MI, often they get mechanical support with balloon pump and or inotropic support along with the vasopressor support. Now, the mortality in this subset of population still remains quite high, which is around 40 to 50% within 30 days. So despite the best effort with immediate revascularization and mechanical support, these patients still are at a high risk of dying from the underlying illness or pathology. So I guess this trial tried to explore the possibility of establishing these patients early on VA ECMO, or in other words, extracorporeal life support. And the rationale for that is probably because the mortality is high, if we do this intervention or extreme form of mechanical support early in the disease process, whether it might help us to prevent or reduce that mortality. And obviously, at the moment, the evidence for use of VA ECMO in this subset of population is extremely poor, and it's based only on some observational studies and very small randomized controlled trials. So I guess there are pros and cons of putting the patient on VA ECMO. It's not a very easy step to undertake. Also, it's very resource intensive. And what are the potential benefits that we are going to get into hemodynamic improvement may be shadowed by the lot of complications such as bleeding, limb ischemia, hemolysis, infections, and just as I said, the cost of the resources involved to set up service. So the ECLS Shock Trial tested the hypothesis that early routine ECLS treatment, as compared to usual medical therapy alone, would result in improved survival in patients with acute myocardial infarction complicated by cardiogenic shock for whom the early revascularization was planned. So Dr. Chacko, can you please walk us through the methodology and the results of this trial, please?
The ECLS Shock Trial was conducted between June 2019 through November 2022 across 44 centers in Germany and Slovenia. The study included patients between 18 to 80 years with cardiogenic shock following acute myocardial infarction who were planned for early revascularization by PCI or CABG. Cardiogenic shock was defined as a systolic PP of less than 90 millimeters of mercury for more than 30 minutes, or the requirement for catecholamine administration to maintain a systolic PP of more than 90, arterial lactate of more than 3 millimoles per liter, and signs of organ hyperperfusion, which could include one of the following criteria, namely altered mental status, cold, clammy extremities, and a urine output of less than 30 mL per hour. So what do they do? After angiographic evaluation of the anatomy and after the decision to revascularize, Patients were randomized in a 1-to-1 ratio to one of two groups of treatment, the conventional therapy arm and the ECLS combined with conventional therapy. They excluded patients who had CPR for more than 45 minutes, those with mechanical causes of cardiogenic shock, and those with severe peripheral vascular disease that did not permit cannula insertion for ECLS. In the conventional therapy combined with ECLS group, which we will call as the ECLS group, ECLS was commenced during the index cardiac catheterization prior to PCI if it was feasible. A distal perfusion catheter was recommended to reduce the likelihood of limb ischemia, which you very often do to maintain perfusion to the lower limb. Techniques of left ventricular unloading and weaning of ECLS were protocolized. And in the conventional therapy group, the treatment was based on current guidelines. The trial protocol discouraged crossover to ECLS. If hemodynamic deterioration occurred, other devices, including intra-aortic balloon pump or the microaxial transvalvular flow pump or the impeller, could be used. Hemodynamic deterioration was defined as impending hemodynamic collapse, arterial lactate of more than 3 millimoles per liter in a 6-hour period, or an increase in the dose of vasopressors by more than 50% of baseline to maintain a MAP of more than 65. Crossover to ECLS was, however, discouraged. How did they calculate the sample size? The authors based the sample size calculation assuming a 30-day mortality of 35% with ECLS and 49% in the control group. So they assumed a 14% difference, absolute difference in the mortality in favor of ECLS. Enrollment of 394 patients provided 80% power to the study at a two-sided alpha level of 0.048 in the final analysis. They plan to enroll 420 patients, allowing a withdrawal rate of approximately 6%. So they did enroll 420 patients. 3 had to be excluded due to lack of informed consent. So the final analysis included 417 patients, 209 in the ECLS group, and 208 in the control group. The mean age of the cohort was 63 years, predominantly male, 81%. 2/3 had ST elevation myocardial infarction, and the most common culprit vessel was the LAD in 47.6% of patients. But most patients had multi-vessel disease. And it's important to remember that the majority of patients, 77.7%, received CPR prior to randomization. Revascularization was most commonly through PCI in 96.6%. Only a very few patients had CABG as a revascularization technique. ECLS therapy was performed for a median duration of 2.7 days. In the control group, 26 patients crossed over to receive ECLS, 22 of them within 24 hours of randomization. So although crossover to the ECLS arm was discouraged, 26 patients ended up crossing over, and most of them, all except 4, went on crossover within 24 hours of randomization. Now let's look at the outcomes. The primary outcome that they looked at was, like in previous studies, the all-cause mortality at 30 days. The 30-day all-cause mortality was comparable in both groups. 47.8% in the ECLS group, which is 100 out of 209, compared to 49%, 102 out of 208 in the control group. The relative risk was 0.98, P of 0.81, so it was not statistically significant. They also performed sensitivity analysis, allowing for patients who had crossed over to the control group by analysis based on the actual treatment received. And here again, the results were similar. They also looked at a few important secondary outcomes, including renal replacement therapy, reinfarction, poor neurological outcome, the duration of mechanical ventilation, time taken for hemodynamic stability, duration of catecholamine support, ICU, and hospital stay. So these were the secondary outcomes that they looked at, but none of these secondary outcomes differed significantly between the two groups. And importantly, among the safety outcomes, we all know that ECLS can be associated with complications, which in fact is one of the major drawbacks of this technique. Moderate or severe bleeding was significantly higher with ECLS, 23.4% compared to the control group, which was just 9.6%. Other complications, including peripheral vascular complications requiring intervention and stroke or systemic embolization, were also higher in the ECLS group. They also performed predefined subgroup analysis of the primary outcome based on age, 65 years and older versus younger, gender, presence of diabetes, presence of ST elevation myocardial infarction, anterior myocardial infarction, arterial lactate levels 3 to 6 versus more than 6, and receipt of cardiopulmonary resuscitation. And among all these subgroups, the 30-day mortality was similar with ECLS and control groups. So what did they conclude? ECLS therapy compared with conventional treatment alone did not improve clinical outcomes, including the 30-day all-cause mortality among patients with acute myocardial infarction complicated by cardiogenic shock who were planned for early revascularization. Complications, including moderate to severe bleeding, were more common with ECLS.
Thanks, Dr. Chakos. So this trial is quite unique, but is that your practice to consider VA ECMO early in the phase of cardiogenic shock?
I must admit that it is not our usual practice. In fact, VA ECMO for cardiogenic shock resulting from myocardial infarction is not very commonly done in a hospital, which is a top-line ECMO center in the country. It is done very sparingly. And in our circumstances, you must also understand that cost is a very important factor. It is okay in patients who have some kind of insurance coverage or who have the means to undergo this therapy, but otherwise, it is extremely exorbitantly expensive for us, and we need to be very choosy in whom we resort to this particular technique. So generally speaking, we do very rarely. The results have not been very promising so far from my own experience.
Yeah, that's correct. And even, I guess, in Australia, in Sydney or Melbourne, this is not a very routine practice to think about putting a patient on VA ECMO when they're in cardiogenic shock, especially when their cutoff was then when they say there's a severe advanced cardiogenic shock requiring lactate level more than 3. And I just don't understand how you can classify that as a severe cardiogenic shock with a lactate of more than 3. Also, the bleeding complications in this trial were like 29% in patient with ECMO group compared to control group. So I'm not very convinced that there's a biological possibility of doing VA ECMO as a part of the early treatment of cardiogenic shock. As authors mentioned, one of the criticism of this trial is whether the argument is the poor results or the poor outcome in the trial group was whether due to primary procedure related or the ECMO related rather than actually the disease process. Again, I'm not very sure why this trial was conducted in the first place. Also, this trial was sponsored by Fresenius. So there are a few things that I'm not very kind of comfortable with this trial. And limitation is obviously this is a blinded trial. And again, that could have been obviously difficult to perform the blinded trial. Then there is a total of 39 patients, even with the smaller patient population, had a crossover to other group. And in 7 patients, this crossover occurred, especially after the refractory cardiac arrest in the control group, where they kind of commenced ECPR. Patient with cardiogenic shock after the myocardial infarction are usually the heterogeneous population. Really, you need to tailor your treatment according to the individual. So using this kind of one size fits all approach, generalizing the VA ECMO for all patients with cardiogenic shock obviously has got potential problems. And I guess when they try to do the subgroup analysis or post-hoc analysis, obviously numbers are pretty small and they really can't draw any conclusion from that. And as you rightly mentioned, even to achieve the generalizability or the external validity for this trial can be quite challenging, because as we are learning more and more about VA ECMO and VA ECMO is becoming a little bit more into the mainstream now, we all are seeing the benefits of doing the VA ECMO in the big centers who are kind of very well-oiled machine rather than doing ECMOs in peripheral centers who do like 1 or 2 VA ECMO per year. And there's really high volume centers are probably the future for these kind of interventions. And unless we have those kind of centers or services available, I think attempting this intervention in patients with severe cardiogenic shock can be quite detrimental. What's your thoughts, Dr. Jacko?
In fact, there has been a meta-analysis of 4 randomized controlled trials, including this one, published in The Lancet just a couple of months ago. And they pretty much reflected the same findings, as in there were 567 patients in this meta-analysis, which is a fairly large number, 284 in the VA ECMO group and 283 in the control group. And they did not find any reduction in the 30-day mortality with the use of extracorporeal life support compared to the control group. And again, in terms of complications, it was far higher with the use of extracorporeal life support. Vascular complications as well as bleeding complications were much more common. So it has been argued that the reason why extracorporeal support may not be beneficial is that whatever advantage there is may be offset by the high incidence of life-threatening complications, including major bleeding, including embolization, hemolysis, and so on. So that's something that you need to consider. So overall, I think you cannot really compare heterogeneous patients with cardiogenic shock, put them all in one basket and say, this is going to help. And also, on the other hand, we really do not know which subgroup of patients are going to benefit. So that requires, I suppose, more focused studies in the future. So at this point of time, across a broad subgroup of patients of cardiogenic shock, the use of ECMO as borne out by 4 randomized controlled trials. Of course, the first 3 were small randomized controlled trials. This is the only big one. And the findings of the meta-analysis also tend to reflect the findings of this study. But even then, you would not really recommend it as a modality of treatment that should be applied in cardiogenic shock following acute myocardial infarction. The other thing is 77.7% of patients in this study had undergone CPR prior to randomization. So that's indeed a very large number of patients who suffered cardiac arrest, had to be resuscitated. And it remains to be seen if in that situation it is really going to be helpful. And longer-term outcomes, particularly in patients who underwent CPR, might be meaningful. Overall, I would still think that as a rule, you shouldn't embark upon VA ECMO across all comers with cardiogenic shock following acute myocardial infarction.
There are a few additional points to what you said. The median age for trial enrollment was 62 in ECLS group. Now, usually VA ECMO benefit will be probably younger population who has got identified reversible cause and underwent revascularization within that first 90 minutes. And if they obviously remain in refractory shock, that's will be my kind of indication for asking for VA ECMO. But pushing the boundary towards the age of 70 or above, I think that's a bit of too much. Also, looking at some of the other criteria for baseline blood pressure targets prior to randomization, the systolic blood pressure in ECMO group was like 95 with a diastolic of 61. Lowest blood pressure was like 82 and range was 80 to 120. So I'm not sure whether that will be the threshold to initiate VA ECMO without thinking about some other additional mechanical support strategies prior to embarking on ECMO straight away. In terms of the ECLS therapy, where it was initiated, 21% of patients, they got actually VA ECMO initiated prior to revascularization, while 26% got during revascularization, and almost 50% got after the revascularization. So again, that's kind of interesting kind of timing wise. It might not be obviously making any much difference, but it just shows that the amount of resources, especially if you're going to initiate ECMO prior to revascularization, will probably switch the focus from actually opening the culprit lesion than thinking about putting the patient on ECMO. And also the key numbers from the primary outcome that kind of stuck with me is the death in both groups is around 47 to 49%, which is quite significant mortality burden with the patient who had myocardial infarction with cardiogenic shock. So this trial gives us that important information about the epidemiology of this disease process. And the second important number is the neurological outcome of CPC 3 or 4. As you mentioned, in 24% or 25% of the patients in ECMO group versus 23% patient in control group actually had a poor neurological outcome. So the mortality is around 50%, and the poor neurological outcome in addition to the mortality is around 25%. So roughly 70 to 75% patients, if they had myocardial infarction and if they develop severe cardiogenic shock, they are not going to do well. And I think that epidemiological data or that information is really crucial and really important for us moving forward, because when we speak with families and inform them about what's the trajectory of this patient will look like, I think these are the numbers which can be quite useful, because that's real world data that we are getting from this trial. Important trial clearly won't change my practice, and I hope people take this trial as probably full stop, or at least at the moment till we get probably a better trial with a different result. But based on this trial and meta-analysis, I think there's enough evidence to say that there is no place for initiation of VA, ECMO, or extracorporeal life support in patients with cardiogenic shock secondary to myocardial infarction.
One of the problems in the conduct of such a trial in the future is going to be, how do you make sure that patients are not crossed over? Because what I foresee is, if you reach a point of no return, most physicians would consider their patients as candidates for ECMO. So crossover will happen, I suppose, even in future studies, and that makes it a little difficult to conduct future studies.
Yeah, that's true. And I guess we really can't avoid that. And I think the reason the crossover will happen is because of the kind of more familiarity with the, but I guess not every center is going to be capable of doing eCPR as well. So I guess those high volume centers can potentially afford to run the trial with some sort of international collaboration. But I agree with you that doing a trial again with this number of patients is going to be extremely challenging. So again, the message is very clear. If you don't have the trial till then, there is no place for VA, ECMO, or extracorporeal life support in this subset of patients. So thanks, Dr. Jaco. That's the end of our today's podcast. We'll be back with another episode in next couple of weeks' time. Till then, goodbye and have a nice time.
Thanks, Sapnil. Thanks, everyone, for listening in. Goodbye.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.